Thanks, Eddie. It's my great honor to be here and have this chance to give this presentation and to share my experience of HIFU treatment for uterine fibroids. High-intensity focused ultrasound is a non-invasive treatment modality. This slide shows how it works. This is the transducer. The ultrasound beams generated from this transducer and focused at some distance away from the surface of the transducer. During the treatment, the ultrasound beams penetrate the human body and focus at the tumor. When the temperature increased to 65 degrees, then necrosis occurred. From the monitoring image from the ultrasound, we will see the grayscale changes like this. So from MRI, we can see the temperature change of the focal region. And this is, you can see, this is the fibroid, and we can see the color changes in this area. When we see the red colors, it means the temperature already increased to 65 degrees. So please pay attention. We'll only see the grayscale, the color changes in this area. This means the temperature changes in this area. So we didn't see any changes, color changes in some other part. It means it is it can be used precisely to ablate the tumor. So this technique was first proposed by the scientists from the US. In 1950s, Dr. Freud used his first prototype to confirm HIFU might be used in clinic in the future. However, this technique didn't develop at a long time because there was no monitoring image at that time. So until 1980s, with the development of the diagnostic image, this technique received international attention again. And Professor Wang from Chongqing, from our university, he started this technique, this study in Chongqing Medical University. This is the transducer he used. At that time, you can see from the black box, this is the water in there, we can see the ultrasound beams from the transducer and just focus at this area. So this is the focal region. We called it acoustic focal region. So after 10 years basic research, so in 1997, Professor Wang published his results, and he first proposed, like they named this necrosis area as a biological focal region. So this is important. The AFR, acoustic focal region, is always the same in the same transducer, but the BFR, that means the biological focal region can be different. So when we use this transducer, when we use HIFU to treat the tumor, if in a safe place, like this, we can use a longer time and higher power and to achieve a large necrosis area in a short time. So when we treat like this area close to the nerve, close to the blood vessels, or like when we treat the uterine fibroids, when we treat the tumor, the fibroids adjacent to the endometrium, we can use a lower power and solicate for a short time to just right to ablate the fibroids without damage to the endometrium. So this is important for us in the clinic to use. So we should understand about this. So in 1997, this technique was first used to treat the patient. This was the first case in the whole wide world. So this patient was osteosarcoma. So we used this technique to, actually the treatment was very successful. In the first case, you can compare this SPECT CT, this before, here is after. So now ultrasound-guided HIFU can be used to treat different type of tumors, like the liver cancer, pancreatic cancer, and bone tumors, or of course, of the uterine fibroids and adenomyosis. In 2004, FDA approved the MR-guided HIFU to be used to treat uterine fibroids. And at the first, like the first stage, first phase, they just use it like to figure out the safety. So only it was not allowed to treat the patient for a longer time. Like they only limited in 4 hours stay in there. They try to treat the patients, but the lung perfused volume was not enough. But anyway, the safety was all right. So the FDA approved this technique, and the INVASIVE can be used to treat uterine fibroids. So now we have 2 types HIFU system. So one is ultrasound-guided HIFU. Another one is MR-guided one. So from the voting and before you raised some questions, I found like 50-50, like some around 50% of the doctors they don't know the difference. 92. I mean, they don't know the difference between MR-guided and ultrasound-guided. So I have the experience with using both. So because in our university, we have MR-guided HIFU and also we have ultrasound-guided HIFU. So I can compare these 2 types of system. So for MR-guided HIFU, because MRI offer the best anatomical resolution, so the image is good. So also they can use this MR-guided MRI to monitor the temperature at the focal region. So in comparison with MR-guided HIFU, ultrasound-guided HIFU can use a grayscale change to monitor the response of the HIFU treatment. But many studies already confirm that's good enough and is reliable if we use grayscale change to monitor the response of HIFU treatment. And the ultrasound-guided HIFU had a lot of advantages of this because the patient was is in the same room with the doctors and the physicians or nurse, so we can communicate with the patient easily. So this system is very friendly. So the patient don't have they are not nervous about the treatment because we are often talk to them, and also it's easy to position the patient because the ultrasound-guided HIFU have the open. We don't have to, like the MR-guided one, to have to move the patient in the ball. So because the ball size is very small, so the patient positioning is very difficult in MR-guided HIFU. So for the room time, the ultrasound-guided HIFU is much shorter, and for the treatment efficiency, ultrasound-guided HIFU is much higher. So of course the cost, MR-guided HIFU is much more expensive. And the most important, the ultrasound-guided HIFU usually can be, it's our tool, it's a gynecologist's tool. For the MR-guided one, have to be used by the radiologist. So this is simply, the difference between the 2 types of system. So now I'm just focused on ultrasound-guided HIFU for uterine fibroids. So we started to use ultrasound-guided HIFU to treat the patients with uterine fibroids in 2000. So the first case was treated in 2000. So, but between 2000 and 2005, this 5 years, it was the first phase. It's clinical studies at this time. So we didn't treat that many patients, but we just use this time to optimize our protocol. So after 5 years in 2005, we have the mature protocol, and also it confirmed the safety and efficacy. So we use this system to treat patients like in routine practice. So 2007, we started use HIFU to treat adenomyosis. I think Professor Ali were introduced HIFU treatment for adenomyosis. Also, we already use this technique to treat some other patients, like patients with placenta accreta, increta, and procreta. And also, we use this system to treat cesarean scar pregnancy and also abdominal wall endometriosis. So for the uterine fibroids, since 2006, because after the first stage, the clinic studies, so between 2006 and 2009, in the 3 years, we use this in our hospital for like just routine practice, clinic practice. Then during this stage, all the patients, we just follow up with MRI for free because we want to see the results. Because at the first stage, the 2000 to 2005, the number was not big. But this time, we have a lot of patients, so we get this results here, like 755 patients in our center. And this baseline characteristics of these patients, you can say we had treated like the submucosal fibroids and also intramural fibroids and also some subserosal fibroids, because we want to see the indication and also optimize the indication. So for this group of patients, the lung perfused volume was 84.8%, so which is very good. So let's say if it's good enough. So you may ask, like some of the patients, you didn't achieve the 100% ablation. So actually, let's see the follow-up results. Like this is before, like the symptoms severity score. This before, you can see 3 months after that, the symptoms much significantly improved and even sustained for 3 years. It means if we achieved non-perfused volume ratio over 80%, the long-term symptoms improvement, some long-term symptom relief can be sustained. So this is the image results. This is before the volume. You can see it's around 140 centimeters cubic. And here is 3 years after that, you can much smaller. So this is the ratio, shrinkage rate. And you can see at the end of the 3 years, it's around 90%. So that's a average at the 3 years. So if we achieved like the lung perfused volume ratio over 80%, the results is good enough. So you may ask, because this is non-invasive, it's different from surgery, it's different from malmectomy. So after the treatment, like we didn't see the tumor, we didn't see the fibroids. How does this tumor go? So you can see this is a multiple uterine fibroids. This patient, like the even small one here, is a bigger one. Of course, this causes symptoms because close to the endometrium. So we treat this case, like 1 day after that, you can see the bigger one and the smaller one, even this one, very small, 1 centimeter. Then we ablated all of them. So you can see low perfusion was completely ablated. Here, 4 months after HIFU treatment, this one was gone. And also we didn't see anything here. Only here, a small part of the treated fibroids of the biggest one but still have something there. So maybe, 2 months later, all the treated fibroids will be disappeared with just a normal uterus. So you can see the shape of the uterus was much better. It's very beautiful. So this is the studies from the US, like Stewart, and he performed malmectomy, and also he performed MR-guided HIFU. So this study from she published, and you can see this is non-perfused volume. So here he said, like if the non-perfused volume ratio reached 70%, the 2 years like interventional re-interventional rate was like 10%. It was good enough because like the malmectomy, the 2 years recurrence rate was over 10%. It means if like the HIFU treatment, if the non-perfused volume reaches 70%, then the 2 years follow-up results like is comparable with malmectomy. So this is some studies from the US and from Japan and also from Canada. And this from a NICE, like the National Institute for Health and Clinical Excellence from the UK. And you can see the non-perfused volume ratio is just likely is around 16%. The 1 year re-interventional rate was 37%, very high. So like if it's reached 55%, the 1 year re-intervention rate was 10%. So the non-perfused volume ratio to achieve is very important to achieve the long-term symptom relief. So here I just want to show you some cases like HIFU for the solid progression.
Prof. Lian, Zhang.
Yes. So that's before. Here's 1 day after it. The tumor was completely ablated. So solitary fibroids. And also we can use this to treat multiple uterine fibroids. For example, like this case, if we perform a malmectomy, the damage will be very big, but we can use it to treat, use HIFU to treat the patient in one session. So to achieve the symptom relief, we can also use this to treat the diffuse uterine neomyomatosis. Like this case, you can see, so no other choice. She didn't want to have the hysterectomy, then we can treat this to achieve the symptom to help the patient to achieve the symptom relief. So just one session, the symptom relieved. So for the pregnancy outcome after HIFU treatment, we already have many papers. The result shows no complication, was good enough for this one. I just want to show you 2 cases. Like this multiple uterine fibroids, if we perform malmectomy, the damage to the uterine wall will be very large. Then we treat it with HIFU. Multiple uterine fibroids, we ablated, but no damage to the normal smooth muscle of the uterus. So 1 month after that, the patient conceived and developed baby at terms. And also this one, the same thing. Some mucosal fibroids we did, and also deliver baby. And also, like I said, for the submucosal fibroids, if the patient wants to go to IVF, we can ablate the fibroids precisely without damage to the endometrium. Like here, the fibroids was completely ablated, no damage to the endometrium. So that's all I want to share with you guys. Thank you very much.